Hello, I'm Andrew Susskind, and I'm a psychotherapist and author based on the west side of Los Angeles since 1992, specializing in trauma and addictive compulsive behaviors. Welcome to my podcast, named after my recent book and workbook, It's Not About the Sex. Here we have direct and honest conversations related to compulsive sexual behavior and trauma, all from a sexual health perspective. Our intention is to offer fresh viewpoints and practical strategies toward establishing greater intimacy and a more deeply connected life. Let's begin. David Fawcett, PhD, LCSW, is a social worker and sex therapist in Fort Lauderdale, specializing in gay men's health. He is the author of Lust, Men, and Meth, A Gay Man's Guide to Sex and Recovery, which explores the intersection of gay men, drug use, and high-risk sexual behavior. He's also the vice president for clinical programming at Seeking Integrity, which develops and operates treatment programs for fused drug and sex behaviors, also known as chemsex, and intimacy disorders. He frequently presents workshops on LGBT health, addiction, HIV, and co-occurring disorders both in the U.S. and internationally. David is a regular contributor to TheBody.com and TheBodyPro.com, writing about HIV, mental health, and substance abuse, and he has been published in Huffington Post, Positively Aware, and other journals. Welcome, David Fawcett. I am so pleased to have you with us today.
It's great to be here. Really appreciate the invitation.
And as I say that, I realize it's Dr. David Fawcett, but since I've known you a while, I will just go with David if that's okay with you.
Blowing a lace skate on that one. I'm very informal about that stuff. So
excellent.
Yeah.
So this is a return visit from David. I'm so happy that you're here with us again. And the reason I wanted you to come back is because of your new book in particular. And I just want to say that out loud, that you had a recent release. It's called Sex Under the Influence, Understanding and Healing from Sexualized Drug Use. And I'm so excited to talk with you more in depth about it because this is actually a newish area for me. And I know a lot of clinicians, even those who specialize in compulsive sexual behavior, don't always know about sexualized drug use. So welcome. And why don't we start with the basic question? What do you mean by the term sexualized drug use?
So sexualized drug use is really a way of putting together multiple addictive disorders in the same kind of package. And so with sexualized drug use, we're talking about some substance involvement, typically amphetamines, but not always. It could be cannabis, often alcohol, even opioids, drugs you don't think of as necessarily sexual drugs, combined with other kinds of sexual behavior. It could be just porn. It could be acting out with other people. It could be the rituals involved with sex addiction, the kind of the preoccupation, all that involving getting ready with alcohol or cannabis or amphetamines, and just woven together. And so when those things become all part of one big addictive ritual, not just a glass of wine before having sex, for example, but just when they're really involved in the whole build-up with the preoccupation, the fantasy, and the acting out, that is when we start to call it sexualized drug use. And that really one goes with the other. And then they really become for a long time, we've looked at it as kind of an interaction of different addictive disorders, where they're not just two at the same time, they're actually tangled up with each other and influencing each other.
That idea of tangled up with one another is quite an image. And I'm wondering if you can disentangle something for us, because the last time you were on the podcast, we talked about chemsex. And so can you distinguish and talk about the difference between chemsex and sexualized drug use?
Yeah, and it's a great question because there's some confusion about this. Really, chemsex is a form of sexualized drug use. With the specific things about chemsex is that it has to do with the population involved. So the term chemsex has been coined to involve men who have sex with men. Typically, it was coined by a guy named David Stewart in London. That was really the focus of my first book, Lust, Men, and Meth. And he meant it to be specific to the kind of cultural experience of men who have sex with men involved with drugs, and sex, but also the stigma that goes with being gay or bi or trans, the shame, the internalized homophobia, the generation that was affected by AIDS that still is kind of has an impact on the mentality of even younger men. So it was that kind of whole package of the cultural setting of sexualized drug use among men who have sex with men. And David Stewart, who coined the term, really wanted the term chemsex to reflect only to men who have sex with men. And so we try to honor that, but it is certainly, I don't want the misinterpretation that that's only a phenomenon of men who have sex with men, because it's a growing phenomenon. Of course, it exists among heterosexuals and everybody else, gay, straight, old, young, and any race, ethnicity. And it's a common factor. And by the way, it's a growing factor too. We're seeing this a lot with so-called heterosexual males right now who are getting involved with the same kind of drugs and have the same kind of sexual behavior. So there's a lot of spillover between the categories, but really chemsex, in short, is sexualized drug use, but among men who have sex with men.
I'm going to ask a naive question. If I'm hearing you correctly, chemsex is a subset of sexualized drug use. Is that how you might look at it?
Absolutely. And it's a subset based on the population parameters and kind of the culture of that specific men who have sex with men population.
Sure.
But the behavior, if we were to extract the behavior to other populations, we would really just call it sexualized drug use. And these are terms in motion that may shake out in 5 years or so, but right now that's kind of where we stand.
Mm-hmm. For instance, you mentioned the idea of someone having a glass of wine before having sex with their partner. And can you explain why that's not an example of sexualized drug use?
Right. And I guess it's a matter of degree, but very often, a lot of people will have, especially use alcohol. Some people may use cannabis or other kinds of drugs that we consider benign, maybe at our peril, because they can be quite dangerous both, but they're used to kind of just loosen up, disinhibit, get comfortable, kind of get into the place. But the sex itself and whatever follows in terms of intimacy, interaction, isn't necessarily dependent on being intoxicated for that. When we're talking about sexualized drug use, there's actually involvement of all those different kinds of drug categories to the point of really pushing the person into a state of intoxication where ultimately their sexual behavior becomes dependent on being in that intoxicated state. Mm-hmm. That's kind of the problem here, is that I have to be high on amphetamines to be sexually aroused, or alcohol or cannabis or whatever. And without it, it just doesn't work. And so that to me is very different than just somebody kind of loosening up before they get intimate with their partner.
Can you say something about poppers? Because I've been hearing more and more clients talk about how they have this need to do poppers before they're having sex. Is that something you've run into?
Absolutely. And it's a huge problem in my mind. Poppers, amyl butyl nitro, for the uninitiated, an old cardiac medication that have been used by a lot of gay and men who have sex with men to kind of get in the headspace of sex. And it has some physiological properties that makes sex more comfortable. Anal sex, for example, it smooths out all the smooth muscles in the body, kind of loosens them and relaxes them. So it's a very different physiological response and a very different head response. And a lot of guys, just because they've been around so long, think of them as just kind of a mainstay of I'll use the shorthand term, gay sex, just because they've been around forever. They're nonetheless not quite benign. They're quite dangerous. And they do have a very powerful head rush. In fact, one of the brand names of poppers is Rush, that really puts people in this space. And I have a lot of clients, whether they approach it initially from the substance side or the sex addiction side, mm-hmm. struggle with this idea of poppers in sobriety, because they kind of think, well, that's a gimme. And it's not. I think it's a very dangerous thing. When we're talking about sexualized drug use, is how certain drugs can put you in that kind of headspace, or they're involved in this preoccupation phase of the addictive cycle, where people are building up and anticipating and making plans and clearing their calendar, talking to their dealer, all that stuff. These are very important drugs as part of that cycle as well. So I really, when I work with my own clients, I really encourage them to look at total abstinence, including poppers. Mm-hmm. And yeah, so it's a big issue for sure.
I think what you said is so important, that it's dangerous and can be something that really detracts from the possible intimacy. Not that every sexual experience has to be intimate, but
Mhm.
what I find again and again is a lot of folks minimize it and say, well, oh, I've been doing it for decades now, or it really helps me enjoy the sex more. And maybe there's some truth, like you said, the muscles soften, or there's things that are advantageous about it, but it's tricky because I think there's this minimization and this misunderstanding of this idea that it's benign when it's not.
Absolutely. I mean, just, it drops your blood pressure. And so a lot of people use Viagra or the erectile dysfunction drugs, which also drop blood pressure. Though even that combination can be quite dangerous
Yeah.
for people using poppers chronically. But I think, yeah, it's something we really have to constantly remind people that just because it's been around and it's familiar and seemingly everybody does it, it still has consequences. And I really appreciate the fact you brought it up. And one of those consequences is this idea of intimacy. When we're using any substance, mood altering drug, it does affect our ability to be intimate. In fact, most people I've worked with, and granted, my mentor once said, "Don't judge the world by your practice," but a lot of the guys I've seen, and women as well, really use drugs as a way to kind of fill in some of their own discomfort around intimacy, right? Being vulnerable, having trust, all that stuff that really, I think, makes a connection worthwhile ultimately. But these drugs often actually interfere with that, and
Sure.
poppers certainly do that as well.
Right. It seems like to me that many therapists specialize in substance addiction or compulsive sexual behavior. Does that have implications for clinical care?
Uh, yes, absolutely, yes. uh, pardon me. So yes, that has huge implications, and I'll tell you what I see, and that is that a lot of our training programs for therapists and counselors really focus on a subset, right? A lot of people work on addictions that look at substances. There's a smaller group that look at sex addiction and porn addiction, but very often those two people don't. They're not the same person, right? They have different ideas of training, and I think particularly the drug treatment industry, which is much bigger and much more common, probably. A lot of the training programs just don't address sex and sexuality in general, and we know that so many um, sexual issues, so many drug problems as well involve sex. And so I think we often find that people are ignoring them in traditional drug treatment centers, or therapists that have been trained with addictions, but not in behavioral addictions. They don't pick it up. And I can't tell you how many clients I've had who have been to numerous, otherwise really well, regarded treatment centers for drug use, who, and the sex part was never addressed. And these are chemsex addicts whose addictive ritual was, getting high on amphetamines and having sex. Well, they treated the amphetamines and literally, and this is a phrase that I hear over and over again, that they were told, well, just get sober, clean and sober, the sex will take care of itself. And we know that as,
Mm.
an addictive element itself, no, it won't, and so and
Right.
then they struggle with sobriety from their drug because every time they engage in sex, they relapse. And so yes, I mean, that's a long-winded answer to your question, but it's a way of really bridging this gap between these two divides, I think, that really end up having our clients do a lot of suffering.
Right. And I'll add a third divide for a moment. I'm really impressed with the work that goes on with sex therapists and clinical sexologists. And oftentimes they have minimal training when it comes to, for sure, sexualized drug use, compulsive sexual behavior. They may know a little bit about it, but don't understand the intricacies and really the art of, like you said, disentangling some of these pieces safely and productively.
I'm a sex therapist as well as a sex addiction therapist, and so I have the training in both. And a lot of my sex therapist friends really look at uh, these behaviors. They want to frame everything in a very sex positive light, and so they'll, I think, really mistakenly or misidentify behavior that's pretty self-destructive in the life of the client, and not really see that for its addictive properties. And I think trying to have other solutions for that, or even excuse it or promote it. And so I think there's some harm that is being done by these divides, these multiple divides.
Right. I actually forgot about your training as a sex therapist, so I appreciate you mentioning that, David. And I have this vision that there can be more bridging between these divides, but it's been a long road, and unfortunately, there's gaps and territoriality, and just unfortunately perpetuating some of the problems that come into our offices.
So, well, like society writ large right now, I think we've divided into compartments and camps, and with some sharp elbows between them. And so I think the more we can talk and communicate, because it's our client, it's the same person, right? The same person that comes into our office may be involved with all of these behaviors and trying to get help from any one of those different professions, and it's harmful to the client ultimately if we don't have some common ground, at least, to talk about and understand what's going on.
Absolutely. So how common is it to transfer addictive impulses to other drugs or to other behaviors? And ultimately, how does that affect SDU or sexualized drug use?
I think the potential to transfer from one addiction to another is really high, unless we deal with what's underneath the addiction in the first place. And I think that's another mistake. A lot of times, addictive treatment in general sort of does a disservice to clients because it just treats the specific addiction itself. And we have ways of doing that and tools for staying away and understanding how it's made us powerless and unmanageable and all that stuff in our lives. But unless we deal with what is underneath it, and that can be, in my case, in the case of my clients, often is trauma. I see awful lot of trauma underlying a lot of addictive disorders, or just other kinds of life constraints, or bad issues, whatever. But they're usually, in my experience, drivers for this behavior. And I think if we just treat the symptom and don't ever address what's underneath it, it's very likely somebody's just going to jump. And I see that I'm in recovery from alcohol and have been for many years. And I see an awful lot of people, people I got sober with years ago who now are 100 pounds overweight, or have gamblers dead, or, because they never really dealt with what the issues were in the first place. And we see this also with people giving up substances. Jumping is a very common one, is to jump into sex and porn addiction. And when I go to AA meetings or NA meetings, I look around, probably have more than half the room are active porn addicts and sex addicts, right? They've just transferred that addiction and they don't really recognize it. So I think that it's very, very likely. And eventually, if you're doing all this transfer of addictions, you're going to eventually come across drugs, and drugs will be part of that. So yeah, people end up with multiple addictions instead of really breaking free from any.
Mm-hmm. So part of what I am hearing you share is that there's these compulsive addictive behaviors that are based in deeper pain, or brokenheartedness, as I sometimes call it. And unless those deeper issues are explored and fully addressed, it's such a vulnerability to relapse, of course. But I also hear that there's some addictive compulsive behaviors that are not identified as a problem. As a matter of fact, sometimes I'll hear people talk about porn like, oh, it's just porn, right? And they're watching porn, 15 hours a week or more. And so I think part of what you're identifying and reminding us is that it's a matter of the individual, in a sense, having that moment of clarity that, yes, this truly is a problem and I need help, right? Just like they did with possibly the original addiction, but with something else, especially with sex and porn, because I think there's so much that's oftentimes endorsed in our culture, oftentimes in gay culture, but in general, really, around sex. So I appreciate the reminder of all of that.
It's so true because oftentimes, and not to vilify porn per se, right? Because some people come to porn, it's perfectly fine, but for other people, it really starts to take some control of their lives, but they don't really see it as such. And that's that's where I think some sex therapists can excuse that behavior, maybe in a too prolonged way, and get somebody in trouble before they kind of realize maybe this is not so benign in that person's life. But I mean, yeah, as we need to really look at how these things all fit together, and I look at addictions really as kind of a maladaptive coping strategy on people's part, right? Because I think most times, and it may be simple enough that if I am a shy person and have a concern about my body, then it makes sense that I might have a beer or two before, trying to get intimate with somebody or having sex or going on a date or whatever, just to kind of bolster myself. But when that becomes dependent, then that's something that really we need to take a look at, that can be really problematic.
Exactly. It's not that harm reduction gets a bad rap all the time, but there are certain camps that talk about harm reduction as not being effective. So what is your idea about harm reduction in terms of sexualized drug use?
It's a great question. I do a lot of work in Europe where harm reduction really is the primary intervention. And for a long time, there was this, and this is true in this country too, of this real antagonism between the treatment folks and the harm reduction folks. And I really have come to view it as a continuum where they're both really beneficial and they have roles to play. But I think harm reduction is very important and powerful and significant for sort of the earlier phases, right? Where people may be using too much or using a method that they don't want to. Maybe they're injecting and that really scares them. They want to cut back. So a harm reduction approach might be to not inject, but maybe smoke or not 3 times a week, but once a week or once every 2 weeks, and just cut back, use less, do it in a safer way. All that. Those are really valid concepts that I think we really need to be aware of. I do believe when it comes to sexualized drug use, however, that people hit a point where it becomes problematic, where they start to have a loss of control over their behavior, where they start to have more consequences, or their life becomes a little bit more unmanageable and they're more powerless over those substances. And at that point, I think sometimes if we continue to just say, well, just cut back or try to do something else, I think we can actually be doing harm for those people. Because at that point, in my book at least, there's an addiction has taken root. And if we kind of try to do less of it, I don't think that's a good strategy. So, but I think there's a role for both. And I think that as I said, I picture it as a continuum where you cross a line. And then at that point, I think we really need to evaluate, is harm reduction really helping or hurting here? And then really look at more strategies to help someone get abstinent.
Sure. So in other words, it's not a cookie cutter approach, but it's more about finding where the person is, what they're willing to do, how we can partner with them in order to keep them out of danger, hence harm reduction. And I just want to also say, and most of our listeners have heard this before, but when it comes to the behavioral type addictions or what we sometimes call process addictions, like sex, money, food, video games, etc., that it's rare that someone is going to go right to an abstinence model. It happens occasionally where someone just says, enough, I'm done, I'm going to move on. But really walking them through the process, and sometimes this is with motivational interviewing or whatever it takes to help them gain agency and trust in us and in the process.
Totally. I think we have to, we start where the client is, right? And what they want. And if somebody comes in questioning their drug use and wondering what they can do about it. If I kind of demand abstinence from the beginning, I'm probably going to lose them and not help them at all, right? And so I think really understanding where they're at, collaborating. And I've been working addictions a long time. Back when I got trained, it was much more confrontational, like kind of getting people's face because they're in denial, and that doesn't work. I think people, at least when I find these days with sexualized drug users, if they're not seem to be getting at it, it's because they're confused and not necessarily resistant. And so I think just helping people start where they're at and what can we do to help them kind of create a plan. This ultimately has to be somebody's own decision. But you're right. And the other thing that you reminded me when you said that is that there's two strategies, right, for sexualized drug use recovery in my book for problematic sexualized drug use. One is, I think at that point, there has to be substance abstinence, but we don't want, the goal is not abstinence from the sex or the sexual behavior, right? We want to integrate sex into our lives in a healthy way. And so, so there, to your point, it's not just going to be abstinence from those behaviors necessarily. People have to eat, right? People have to have sex. People have to do certain things that unfortunately can become addictive in certain cases. So like, yeah, each case on its own individual merits, I think is really important. And in a very non-judgmental way. The other, again, the universal thing, I know trauma is a big one in my book, but the other thing that I see underlying all this is shame. There's just so much shame.
Yeah.
And I think that was the hallmark of what David Stewart saw in the MSM community when he coined the term chemsex as well. But again, no, men who have sex with men have no monopoly on shame, right? It's a universal theme. And I think if a client, a very wise client, once reminded a group I was running, said, shame doesn't heal shame. And so I think if we as therapists or as peers really confront people or shame them in a way, that's not helpful, right? That's not helpful. I think really that collaborative approach is best.
Yeah, I was going to say it's like salt in the wound, and that's the last thing we want to do. Yeah,
exactly.
Can you share some recovery strategies for those listening to our episode today?
Yeah, I think it really depends on where people are at, but I'll highlight some of the ones I think are important for people, maybe sort of discovering they might be a sexualized drug user or wondering if they are, and what kind of strategies would be useful for them. And I think there's a couple that I think are really important from the sex addiction world, if you will. And then one is the role of fantasy. And I think this is something that is a huge part of SD or sexualized drug use that a lot of traditional drug treatment programs don't even recognize. But out of necessity, I think a lot of people that work with sexual disorders do. And that role of fantasy where people are getting high, right? It's not the level of dopamine I might get if I, inject methamphetamine, but I'm getting a lot of dopamine fantasizing about what's going to happen. And I think when we're talking about this untangling of sex and intimacy and in sobriety, what really holds people back sometimes, they continue to spend a lot of time in fantasy. And really those drug-related arousal elements are there. And so I think to really be conscious of our thoughts. So I do a lot of mindfulness-based stuff. I do a lot of DBT or dialectical behavioral therapy skill sets. I think one of the things we see is just a lot of distress tolerance skills that are lacking in a lot of people. So learning how to deal with boredom, which is a huge trigger for a lot of people. Learning how to deal with an uncomfortable feeling, how to assert, that stuff, little sort of daily things we, some could come easily to some, but not to others. And it's just helping people develop those skills. And then finally, in these more, maybe the longer arc of recovery is that the intimacy skills and healthy sexuality skills. I think a lot of people get sober to their credit, but they don't know okay, now what? And so, learning, we break down intimacy, it's being vulnerable. It's learning how to trust. It's all these, it's kind of skill sets that we can learn. I think practicing those and these are, it's easy for me to tick those off in 60 seconds, but that takes a lot of work, of course, to do, and a lot of, it's a slow process. But I think those are the nature of the kind of skills that I think are important.
Can you go back to fantasy for just a moment and share just one example that you see the most when it comes to fantasy associated with problematic sexualized drug use?
I've worked mostly with men who have sex with men who've used amphetamines, specifically meth and sex. And meth is just hijacks people's sexual drive and arousal templates in a big way. So when they get sober, therefore, there's often a period of actual sexual anorexia that sets in because their sexual arousal has been so dependent on that heightened amphetamine state that when they're not there, they just literally can't get aroused. And that starts to correct itself. But it can take a long time, especially for a meth user, 6 months, 9 months even. And a lot of that has to do with brain repair, with dopamine transporters and physiological things. But what I see specific to fantasy is that people will get frustrated because they can't maintain an erection. They have trouble getting an orgasm. And so just for the briefest moment, 10 seconds, 15 seconds, just to have an orgasm or to just finish this thing, which may have gone on too long, right? They'll go back to a meth fantasy. And they haven't put a drug in their body for a year.
Right.
But they still are using that meth, and that does the trick, right? Immediately there they are. But every time they do that, they're reinforcing that particular pathway, they're reinforcing that fantasy, and they're kind of slowing down or stopping their sexual recovery. And so that's where fantasy is really can play a deleterious role here in sort of slowing people down. And I've seen also people, they're not getting high to the level they were. They're not putting drugs in their body, but they're still using fantasy and the dissociative properties that come with fantasy. That's sort of disconnecting from pain or boredom or whatever. They're still using that as a way to deal with that instead of more healthier ways to deal with it. And so I think fantasy is a little bit of self-medication that we often see. That's kind of people think, well, that's not on my sobriety plan, but it is on my clients. I've sort of included, let's be careful where our thoughts go because it can really slow you down.
Thank you so much for that clarification. I don't know if I've ever heard a better description of how fantasy, or I believe what you were referring to, some euphoric recall, was how that can be used as an attempt actually to feel better, right? And in a sense, they're drawing upon what's in the brain to try and get off or whatever the case may be. But at the same time, it perpetuates or keeps that well-worn path a deeper groove rather than finding another way to be more in the present tense.
And with sexualized drug use, that newer way is not going to be as intense, frankly, for sex and porn addiction too.
Yeah.
Right? It doesn't have the intensity.
Right.
I think you talk to people who are sober a long time, it's actually a much richer experience in the long run, but it's just different.
Right.
And I think people are trying, was one client told me early on, he said, I want to have meth sex without the meth. Well, yeah, okay.
Right.
That's not going to happen.
If it only so simple, right?
Right, exactly.
I think it was Carnes who said something about intensity versus intimacy a long time ago.
Yes.
So this is not a new concept, but it is something that is still alive and well in a way in terms of the therapeutic direction from fantasy to reality, from intensity to intimacy.
In fact, if anything, over the course of my practice, it seems to have gotten worse. Like people are dropping into that.
Yeah.
And maybe because of the rise of video and computers, and it's so easy to, we spend a lot of our day there anyway, right? It's just, not necessarily as a way to distract or dissociate, but it's easy for us to make that jump. And we do.
Yeah. So we're almost running out of time for today, but I wanted to share a few things. So first of all, I know, David, that you had a book back in 2015 called Lust, Men, and Meth, A Gay Man's Guide to Sex and Recovery. So that was a few years ago, but an important resource to mention. And then I'm just going to mention your recent release, 2024, Sex Under the Influence, Understanding and Healing from Sexualized Drug Use. And I think we got a nice snippet today, a nice short summary of maybe what is detailed more in the book. But knowing you, David, I can only imagine that both resources both resources for different people could be really valuable and healing. So where is your new book available, and in what forms is it available?
Yeah, it is on Amazon. It's available in print or as an ebook. It will come out in an audio version probably within the next 6 months or so. But at the present time, it's in print and electronic version.
Excellent. And if someone wanted to reach you, how can our listeners reach you for more information?
Right. My website is david-fawcett.com. So DAVID-Fawcett, FAWCETT.com. And there's a way to contact me directly through the website.
And you're based in Southern Florida, but it sounds like you're globetrotting a bit. Where in Europe are you teaching or training?
For a number of years, I've worked in the Netherlands with an organization called Mainline, which is they do harm reduction actually globally, but after the UK, meth jumped to Amsterdam around 2015, like overnight. And so they were ready for it, largely because we were working together. So more recently in Scandinavia, I've been working in Norway a lot with an organization called Tim Friendly. So yeah, it's quite a bit. And then of course I'm in LA a lot as well.
Right.
I set up the program at Seek Integrity. I'm not there as often as I used to be, but I'm still proud of that program.
Sure. And the folks in Europe are very fortunate to have you and to have the expertise and the outlook that you bring. I mean, you come from so many different kinds of training and of course, decades and decades of doing this work. So it's been such a pleasure, as always, having you here today. Thank you so much for sharing the time.
Thanks, Andrew. It's always a pleasure to be with you too. Really appreciate it.
Thanks for listening today. It was wonderful sharing the time with my colleague and friend, Dr. David Fawcett, and discussing this really meaningful and sometimes misunderstood topic. He can be reached through his website at david-fawcett.com. If you're so inclined, please give us a 5-star rating and be sure to subscribe and share my podcast with those who may benefit. I look forward to you joining us the next time, and don't forget to stay connected.